All right, party people, we are back at it with another one. Let's get it. So we've got a 5-year-old boy with a fracture in his humerus. It mentions normal sclera. Now, when you see fractures in pediatric cases, your mind should immediately be jumping to a few differentials, that being child abuse, OI, that's osteogenesis imperfecta, and osteopetrosis. Now, in this vignette, when they say normal sclera, this helps you rule out OI. Because if they want OI, they will present a child with blue sclera, and then you are supposed to deduce that they have a defective type 1 collagen. Now, if there's no mention of red flags for abuse, like behavioral concerns, poor eye contact, avoidance, cigarette burns, cigar burns, bruises, multiple fractures at various stages of healing, child abuse is unlikely. This question is not presented to you in that way. Now, I could have showed you an x-ray here, but it's not necessary because you're not a radiologist. I'm not a radiologist, it doesn't matter. But what we're trying to do is get you to connect the dots that point towards osteopetrosis. Now, if you're unfamiliar with osteopetrosis, don't worry about it. We're about to break it down. Now, in terms of pathophysiology, for osteopetrosis, aka Albers-Schomburg syndrome, osteopetrosis is caused by deficiency in carbonic anhydrase 2. This enzyme is found in osteoclasts. Normally, osteoclasts break down bone by pumping protons into the bone to create an acidic environment that resorbs the bone matrix. Now, to generate these protons, they use carbonic anhydrase 2. Now, the normal formula is CO2 plus H2O, gives you H2CO3, which is then converted into H plus, the hydrogen ions, and bicarb. All right? Now, in this case, if you have a deficiency in this enzyme, this would result in impaired osteoclast function. If you have impaired osteoclasts, then you have decreased bone resorption. Therefore, in turn, you'll have increased bone density, dense bones, but they will be weak because of the architectural deficits. This results in fractures. So even though bones may appear strong and dense, they're actually fragile. This is a key concept. So if you saw an x-ray, you would see bones that are shining bright white. That doesn't mean that they're strong. This actually is a pathology. Now, in terms of the question, they're asking you about the enzyme deficiency, all right, so we know that being carbonic anhydrase 2, but they also wanted to connect to a drug that inhibits this enzyme. Then we have to connect that to acetazolamide. Now, if they're asking you for urinary findings in terms of this drug, the key detail here is urinary, not serum. This is easy to mix up, so you just have to pay attention. Now, in terms of carbonic anhydrase in the kidney, carbonic anhydrase is also found in the PCT. Now, here it's going to have the same function, where bicarb is resorbed back into the bloodstream, and protons are secreted into the urine. This makes the urine more acidic. However, if we administer a drug like acetazolamide, this is a carbonic anhydrase inhibitor. The reaction that we just went over is blocked. Therefore, the CO2 plus water plus H2O cannot be converted into H2CO3, and in turn cannot be converted into the proton as well as bicarb. Therefore, less bicarb is reabsorbed, more ends up in the urine, fewer protons are secreted, and the urine becomes more alkaline. So, in terms of how to think about this situation, if I'm going to ask you about the urinary effects of acetazolamide, we're covering it again. You'll have an increase in urinary bicarb. You will have an increase in urinary pH. Your urine becomes alkaline. That makes sense. Your urine volume will increase. Well, that also makes sense because acetazolamide is a diuretic. And urine osmolality will decrease. This is due to the increased free water loss and resulting decreased concentrated urine. Even though ion resorption happens downstream in the nephron, the overall solute concentration decreases thanks to the diuretic effect in the early PCT. So, once again, in the clinical scenario for your licensing exams, let's spin the block. First, you have a pediatric fracture, you're thinking child abuse, OI, or osteopetrosis. Next up, if they show you dense bones on x-ray plus normal sclera, now you're thinking osteopetrosis. They want to know about the enzyme deficiency, you're going to tell them carbonic anhydrase 2. And if they ask you about the inhibitor of said enzyme, we're going with acetazolamide. Now, if they ask you about urinary findings, you will tell them your bicarb in the urine will increase. Your pH will in turn increase. Osmolality will be down despite the volume being up. So this isn't very difficult, but it is easy to mess up if you're not clear on the concepts. So we're just trying to get this straightened out in your brain so that when you do this on your licensing exams, you're able to walk through it with ease. All right? That's it for this one. If you like the video, subscribe, and go crush it.